So GLP drugs is not for you. They're not for you if you're a person who's taking them for a short-term weight loss, if you're a person who's not serious about changing your lifestyle. And because the obesity epidemic is ramping up and people are struggling to find ways to control their weight, the fact that these drugs could reduce your weight, that really caught up. And a lot of people started taking these drugs to become slimmer.
We hear people who have started on these medications that they say that simply don't feel hungry. It's quite unbelievable. Right. So what do these medications actually do to our body, whether it's to the brain, our appetite or our metabolism? Can you just...
And it is basically, this is what is the main mechanism of weight loss, that you start eating a lot less than you would normally be eating without the drug. So if somebody has having advanced fatty liver disease, which is causing liver fibrosis or progressing towards advanced liver disease, then such a patient can actually reverse the liver disease by going on these drugs. These drugs have shown potential that they can reverse this condition. They can convert the fatty liver to a non-fatty liver. That happens when you lose weight.
Hello everyone and welcome back. Now, would you believe that the medication which was developed to treat diabetes is now changing the way the world thinks about weight loss? It's been called the super drug or the miracle drug, but still surrounded by lots of controversies, myths, and endless social media buzz. So what's the real story? What are the side effects? Who should be taking these medications? And are they the real future of diabetes and obesity treatment? Today, we are diving into one of the most talked about advances in modern medicine, GLP-1 medications. And to help us separate science from sensationalism, we have with us our expert endocrinologist, Dr. Nishant Raizada, with us.
Thank you.
Dr. Nishant, welcome to the show.
Thank you very much.
Okay, Dr. Nishant, we have been, wherever you look in the social media or celebrity interviews, people have been talking about Ozempic, Mounjaro, and the GLP-1 agonists. And they have taken the internet by storm and people are talking everywhere. So let's start with the basics. What are these medications actually, and why have they reached such a global phenomenon?
So these GLP-1 drugs, basically, they mimic a hormone produced in the body. So this hormone called glucagon-like peptide is produced by the intestines. And this had some role to play in the satiety and also in the blood sugar control. And these medications mimic this hormone. And it was found later on, after the initial development for diabetes, that they are capable of causing weight loss. And because the obesity epidemic is ramping up and people are struggling to find ways to control their weight, the fact that these drugs could reduce your weight, that really caught up. And a lot of people started taking these drugs to become slimmer.
Okay. So, when we're talking about these GLP-1 agonists, we are hearing about dual agonists, we are hearing about triple agonists. So can you actually simplify them a bit and tell us how are they different?
Right. So the dominant molecule so far has been GLP-1, which is glucagon-like peptide 1. So glucagon is a hormone produced by the pancreas, and there was another hormone, as I mentioned, the GLP-1, which is structurally similar to glucagon. So they called it glucagon-like peptide 1. So this is the initial drug. This is known as Ozempic or Wegovy in the common markets, and the Semaglutide, which is active agent. And then later on, they developed dual agonists in which two hormones would be put together. So you have a GLP-1 plus a GIP, gastrointestinal inhibitory polypeptide, GIP. So the combination of these two is in a drug called Tirzepatide, and they're now coming up with a triple agonist, which has got another hormone added, and that is glucagon, and that is called Retatrutide. That is the triple agonist. So basically, they are combinations of different hormones which is being produced in the body. So they make agonists of these hormones and then they synthesize them.
Okay. So really, it's quite fascinating that these drugs were actually made for diabetes. So at what point did the medical community think that they could be used for weight loss?
Right. So the story is quite interesting. So the scientists back in the 80s did an experiment and they figured out that if we give glucose by mouth, the amount of insulin the body produces in response to it is much more than that if you give the same glucose by directly into a blood-through injection. So they propose that the intestines or the stomach secrete some hormones which signal to the body that glucose is coming, and so the insulin response is greater. Not just about the blood glucose level, it is also about from where it is coming. And one of these hormones was later found to be GLP-1. And but in the body, the GLP-1 is produced in small quantities, and the endogenous GLP-1 lasts only for a few minutes. The main work of this hormone was to increase the insulin secretion from the pancreas, and it would also to some extent cause some level of satiety. It would signal that you've had food. So later on, the scientists found that this particular GLP-1 like substance is also present in some other animals, most important being the Gila monster. So this is a kind of a lizard which is found in parts of America. And what the scientists found that this lizard used to eat very infrequently. It will eat once, maybe a month, and then for several months it will go without eating. So they figured out that this may also have some potential role in controlling the appetite. So the initial development of these drugs was mainly for diabetes because the insulin secretion was better, and the initial drugs did show good response in the diabetics. But the researchers noted that apart from causing improvement in blood glucose, they were also causing weight loss. And because there were very few good weight loss drugs back then, the potential of these drugs for weight loss was immediately understood. And some of the earlier congeners were approved for obesity, the first one being liraglutide. The weight loss caused by liraglutide, however, was smaller because liraglutide was not as strong stimulator of the GLP-1 receptor than the newer drugs. And when they figured out that liraglutide does a good job, they came up with even stronger agonists. And then we have semaglutide, which is capable of causing much more weight loss. So this is how the story panned out.
Okay, it's quite interesting. So coming to when we hear people who have started on these medications that they say that simply don't feel hungry. It's quite unbelievable. So what do these medications actually do to our body, whether it's to the brain, our appetite, or our metabolism? Can you just speak?
So the initial focus, as I said, was mainly upon the insulin stimulated by the GLP-1. But it was later understood that this molecule has got multiple actions. So it grows to your brain. And in your brain, there is a balance of hormones which cause hunger and the other hormones which cause satiety. So it alters the balance in favor of the satiety hormones. So even without eating a lot, you feel a little fuller. And it also blocks some of the reward centers. So we've got a dopaminergic reward center in the brain. Whenever we eat something very sweet or with something which we like, we get a dopamine hit. So this drug kind of blocks that hit. So you don't get the same kind of high from eating, maybe a piece of chocolate which you like, or maybe an ice cream, which you would getting earlier without the drug. So by killing these cravings and by producing satiety, it is able to make you eat much less than you would normally be eating. And it is basically, this is what is the main mechanism of weight loss, that you start eating a lot less than you would normally be eating without the drug.
Okay. So, early on we used to say, even now that for obesity treatment, we would say exercise and diet.
Right.
So has that taken a backseat with the GLP-1 medications?
It has not, and it should not. But unfortunately, a lot of people are taking the drug without proper guidance. So the key pillars of weight loss still are a healthy diet and regular exercise. It is only the cravings part, or if the people are not able to stick to their diet, only that gap should be filled by the GLP-1 drugs. For example, these drugs will make you eat less than before and maybe reduce your cravings. But if you haven't learned about what is a healthy diet and you eat high calorie foods even while on the drug, you may not lose a lot of weight. Because to lose weight, you need to have a calorie deficit. The amount of calories body requires should be less than what you're eating. So your amount of food will go down when you are on GLP-1. But if you eat the high calorie food in that particular bracket, then you may not have a calorie deficit, and then you may not lose weight at all, or you may lose a very little weight. So these drugs have not at all replaced the diet and exercise. They are in fact a good adjunct to diet and exercise. And basically people who are struggling with weight loss despite following diet and exercise, they'll get a push with this drug and it will motivate them and help them achieve their weight loss targets.
Okay. So, say someone watching us, during this conversation and wondering, and is a little overweight and is wondering that should I ask my doctor to start these medications? So, the question to you is, who is the ideal candidate, and most importantly, who should not be taking these medications?
So GLP drugs is not for you. They're not for you if you're a person who's taking them for a short-term weight loss, if you're a person who's not serious about changing your lifestyle. They're not for you if you plan to stop the drug after a few months of therapy. They are not for you also if you have some pre-existing medical conditions such as pancreatitis, or you have a thyroid cancer history. In those conditions, you are not a good candidate. But if you're somebody who's serious about your weight loss, somebody who's willing to change your lifestyle, somebody who's going to take a good diet, including a high protein diet, and do the resistance exercises which is prescribed, then you are a good candidate for GLP-1 drugs.
What we're understanding is where weight loss gets all the headlines, it's actually the other impact on the other organs also. Is there any impact on the brain or the gut as well?
The impact on brain we discussed already. It's mainly related to satiety and on reduction of these cravings. Another interesting thing that has been found out is that even the cravings for alcohol also reduce. A lot of people who were earlier consuming alcohol report that they no longer feel the need to take alcohol. To my knowledge, there is no scientific approval to use this drug for stopping alcohol, but this is something which everybody is observing, that cravings for alcohol are coming down. So, with regards to brain, this is the main action. With respect to gut, of course, it causes some delay in gastric emptying, so you feel full for a longer time. So you eat a meal, and you for a few hours you feel the stomach is still full with that meal. So that also contributes to satiety and produces some weight loss. But the main mechanism of weight loss still remains the reduced appetite, which comes from the brain.
So once people are started on medications, they expect dramatic results like overnight. So what is the realistic time for weight loss, and what how do we notice or monitor that?
Right, that's a good question. So the weight loss begins gradually, and the maximum weight loss is seen roughly at around 1 year of therapy. In fact, the initial 3-4 months would be reserved for dose escalation. So these drugs have 4-5 gradation of doses. You start with the smallest dose and then you gradually increase the dose up. So it will take you 3-4 months to reach your maximum tolerated dose. And when that dose runs for another 6-8 months, then you see the maximum weight loss. So typically in the trials, they have found that maximum weight loss occurs at 1 year of therapy.
Okay.
And weight loss may not be a linear decrease in weight. Initial few months, sometimes weight loss is not much. Once you reach your proper dose, only then you have. But again, there's a lot of heterogeneity. Some people start to lose weight in the first month itself. Other people would not lose much in the first 3-4 months and then suddenly lose in the last few months. So it's not very smooth in that sense. But as I said, maximum weight loss would be at 1 year of therapy.
So, whenever a treatment becomes popular, people are worried about side effects. So, would you like to say about certain side effects which are worrisome, and more so, what could be the warning signs?
Right. So I would not call this exactly side effect because this is normal physiology. So whenever you lose weight, you don't just lose fat, you also lose muscle. And this is a basic rule of weight loss, that whenever you lose weight, 30% of what you've lost is actually lean muscle. So if I lose 10 kg weight today, 7 kg will be fat, 3 kg will be muscle. And this is independent of how I lose the weight, whether I do it by dieting or I took GLP-1 drugs, either which ways. So now, because these drugs are capable of causing weight loss in excess of 10 kilograms, there can be a significant reduction in your muscle mass if you do not take the necessary precautions which we recommend with these drugs. And those two precautions mainly are eating a high protein diet and engaging in resistance exercise, muscle training exercises. So if you're not doing that, you'll end up losing muscle. So that is one of the most relevant concerns for a person who is on these drugs. The other adverse effects of these drugs mostly are not very severe or not very serious. So you will have some nausea in the beginning. Some people may even have vomitings if they eat a lot of food, because your appetite would come down. Some people complain of diarrhea also. Because your water intake reduces, your fiber intake also reduces because you eat less. You might also develop constipation. Then some people may develop gallstones, but again, gallstone can happen in any patient who suddenly lost weight. So if you lose weight in a 1 year from 10-15 kgs, appearance of gallstone is expected whether you take these drugs or do not take these drugs. So the major side effects that are being seen are mainly these which I've told you.
Okay, so what happens if somebody stops taking these medications? There is a myth, a lot of myth, or the usual social media talking going around that weight is regained. There could be facial hair and so many things. So
Uh, so, as I said, now we are moving to a concept where obesity is considered like a chronic disease. Just like diabetes and hypertension are with you lifelong, similarly, obesity is thought to be something which will continue with you. And therefore, most of the scientific bodies are now suggesting that if you are using drugs to reduce your weight, there is no reason for you to discontinue them at any point of time. It has been observed in the trial that when you stop the drug, then over the next 1 year, a majority of people do regain the weight back. But again, I'll put a caveat out here. Weight regain occurs when you are in a caloric excess. You are eating more calories than what your body needs. Now, if you start taking Ozempic or Mounjaro, whatever drug, and you do not put any attention to your weight or your diet, you do not change your diet lifestyle, you continue to eat the same unhealthy food, you continue to not do exercise, then whenever you stop the drug, the same things which caused your weight loss before are still there, and they'll again cause the weight regain. That said and done, if we are giving the drug for medical reasons, I would say there is no reason to discontinue. We should continue these drugs indefinitely, just like we continue diabetes medication. But if you are somebody who's thinking of stopping these drugs, if you're already on the drugs and stopping the drugs, you have to be very cautious. You must ensure that your lifestyle has changed, your diet has changed, and then you're very careful after you stop the drug. Because if you do not pay attention, then you might regain the weight back.
So, coming back to diabetes, this patient is started on GLP-1 medications. Is it correct that the patient can achieve remission, as in diabetes is gone for good?
This is not true for everybody. People who are markedly obese and who have diabetes for a short duration and who do not have very severe diabetes, that is, they're controlled on only one or two oral medications, those patients might develop remission of diabetes. Again, I'll say might because not everybody will do that. For a lot of people, the defect in diabetes is a beta cell dysfunction of the cell secreting insulin, and that may not reverse completely. But still, we've seen a good number of patients who were markedly obese, had diabetes for only 3-4 years, and who were on few drugs, and they were able to achieve normal glucose without any other drugs. That being said, what people should understand, diabetes remission does not mean that you will eat anything and blood sugar will not rise. It only means that you are able to achieve a normal HbA1c without taking any medications for diabetes. So that remission entails that you are continuing to do your diet, continue to do your exercise, but you are still having a normal A1c without taking any drugs. And that is possible for a few patients, but not for everybody.
Okay. So one more important is you have already mentioned earlier that a lot of people want to lose that extra kilo for cosmetic reasons. So if a patient comes to you for such reason, where do you draw the ethical and the medical line?
With regards to the ethical part, it's no longer an ethical issue because these drugs have received approval for treatment of obesity per se. So, as a doctor, if the person is meeting the criteria, the BMI criteria that we have, or for that matter, even the waist criteria that we have, then that person is diagnosed as person with obesity, and we can give the drug without any ethical issue or a medical legal issue. But the main concern remains that what is the intent behind the weight loss? So, as I said before, if you're not serious about the weight loss, then these drugs will do more harm than benefit. And this ties into my previous explanation regarding the muscle loss part. So, as I said, if you lose weight, you lose 30% as muscle. So, if I am, let's say, a person who is 100 kgs in body weight and I am having 30 kilograms of muscle in my body, I lose 10 kg, I come down to 90. So, I've also lost 3 kg muscle. So, my muscle has gone from 30 to 27, 30 kilograms to 27 kilograms. Now, if I take the drug and after some time I stop the drug, I regain the weight back. I will not regain the muscle back. I'll only regain the fat. So now I'm back to 100 kg, but now my muscle mass is still 27. So now I have become a person with less muscle, which means number one, I am weaker than before. Number two, most important, that now my metabolism is slower because it is the muscles of the body which use most of the calories that we consume. And if our muscle mass is reduced, then our body needs lesser calories. And therefore, gaining weight now will become faster. And conversely, losing weight will become more and more difficult. So if you do this repeatedly, multiple cycles, you will become a sarcopenic person with very low muscle mass, who will find it almost impossible to lose weight even when eating very small quantities of food. So therefore, whosoever is starting these drugs must be very sure about that they want to change the lifestyle completely and take a long-term plan. And they must ensure that they take adequate amounts of protein and do physical exercise, especially resistance training, so that they can minimize the muscle loss. By doing this high-protein diet and doing resistance exercise, you can reduce the muscle loss to almost 10% rather than 30%. So if you are a person who's doing all this and who was likely to ensure to sticking to this diet whenever they stop the drug, only then are you a good candidate for this drug. Otherwise, in the long run, you'll find you'll become more unhealthy if you use these drugs without guidance for a short period of time.
So bottom line, diet and exercise remains.
Absolutely.
Yeah. So one term which has gone really viral online is the Ozempic Bride. So what do you think is happening there about this unrealistic or realistic trend? Where do you take side?
So, obesity, as you know, is becoming rampant. Everybody is gaining weight, and it's mainly because of the lifestyle. We are eating high calorie food, very little exercise for most people. But then we want to look good in our photographs. And for all the girls, their marriage is the big day. They want to look nice on the big day and they want to remember those images forever. So, a lot of them are get motivated by listening to or watching this on social media that people have lost weight by using these drugs like Ozempic. and it looks like a easy way to quickly drop a few kilograms and fit into those lehengas or whatever bridal suits they want to wear. Their drugs work. There's no doubt about it. So people are using it. But the main harm in this, as I mentioned to you, is number one, many of them are taking these drugs without medical supervision. So there are some contraindications. In some conditions, you cannot use these medications. So they may not be aware of that. So they might end up taking this medication when they should not be taking. And number two, of course, they generally do this without following a proper diet and exercise regimen. And as I told before, they'll have muscle loss also. And then they generally what they do, they take it for a few months before the wedding and then they stop. And if you see, after wedding, after marriage is the time when most females tend to gain a lot of weight. And this has been observed for many years. We're not sure what is the reason behind it, but this is what happens. And if you add to it the stopping of these drugs, you'll have a very sudden weight gain after the marriage. And then this would translate into greater risk of gestational diabetes, that is diabetes in pregnancy, and greater risk of other diseases in the long term. So this trend, I'll say, is a very unhealthy trend. It could potentially be dangerous also. So we should try to lose weight by healthy measures. There's nothing wrong with thinking about using these drugs for weight loss if you're obese, but then you should have proper guidance and do it as a long-term plan, not as a short-term fix.
That's a very good advice. So, as an endocrinologist, you have a wide range of drugs, I mean, for treatment of diabetes, starting from the earlier ones to the newer ones. So, how do you decide which patient to go on which medication?
So conventionally, what we used to be taught and what we used to practice was that metformin would be the first drug that we would give. And then other drugs would be added on top of metformin because metformin was the older drugs and had good responses and very less side effects. But now with the coming of these medications, the GLP-1 agonist and the SGLT2 inhibitors also, these drugs have got specific advantages in specific conditions. So people who are already having heart disease, you already have some stents put in or you had a bypass surgery or there's a known blockage in your heart, your risk of getting hospitalized or your risk of getting an MI are reduced if you are on certain drugs. And one of these drugs is GLP-1 agonist. So if a patient comes to me who has diabetes and also has a known heart disease, then I would prefer to give him GLP-1 as my first drug and then add other drugs on top of that. More recently, the GLP-1 drugs have shown very good results in patients who have diabetes along with kidney problems. So if you have kidney disease, these drugs are known to reduce your creatinine level, which is the KFT parameter. And some patients with diabetes have what is called as proteinuria. So they are losing protein in the urine, and that is an early marker of diabetic kidney disease. And these drugs have shown the ability to reduce this protein leakage also. So again, somebody who has diabetes and a kidney disease, I would try to prefer as GLP-1. Then thirdly, there is a condition called fatty liver disease, which is now called MASLD. Earlier it was called non-alcoholic fatty liver disease. And this disease is now gradually becoming the leading cause of liver failure. So again, these drugs have shown potential that they can reverse this condition. They can convert the fatty liver to a non-fatty liver. That happens when you lose weight. And even if you have some fibrosis in the liver, which is a little advanced stage of the fatty liver, even those stages can be reversed by these medications. So again, people who are having this condition again become good candidates. Then thirdly, as you were mentioning earlier, is remission of diabetes possible? So if I have a young patient who's obese and who has on a couple of drugs only, I would think in terms of having a remission for that patient, and I would prefer GLP-1 in those conditions also. So broadly, these are the conditions in which GLP-1 drugs become preferable. Apart from that, anybody with diabetes who is obese is automatically becomes a good candidate because this drug tackles both the problems.
So there's also some discussion that diabetic retinopathy worsens while on GLP-1 medication. So what's your take on that?
So that is not specific to GLP-1 drugs itself. If you have diabetic retinopathy and you have high blood sugars, any sudden reduction in blood sugars, be it by insulin or GLP-1 or oral drugs, can precipitate a transient worsening of retinopathy. So people who are having advanced retinopathy and if they have very high blood sugars, we are a little slow about treating them. We try to bring down the glucose a little slower than normal. We'll try to go to a normal range in 3 months rather than in 1 month flat. So because these drugs have the potential to cause sudden weight loss and also sudden improvement in glucose, they can potentially worsen if not given correctly. But then again, the dosing is in your hands. If you start with a small dose and you escalate it slowly, you can prevent the sudden drop in glucose, which causes worsening of retinopathy. Apart from that, if you follow this particular caveat, there is no worsening of retinopathy per se.
Okay. So modern medicine is, going incredibly fast, and we are getting to see so many new developments in drugs. So, do you think we are entering into a whole new era of treating diabetes and obesity? And what really excites you about the future?
Yeah, this is a very exciting development because, as I mentioned, the earlier we didn't have any drugs to reverse kidney disease or to reverse the fatty liver disease, and these drugs, both semaglutide and tirzepatide, have shown potential in reversing these conditions. Then we are coming up with the newer drugs, as you were asked earlier about the dual and triple agonists, and those drugs have potential to cause even greater weight loss, and therefore the chances of remission of diabetes in young diabetics who have just started with type 2 diabetes also become higher. Then they are coming up with newer molecules which will help you in preventing muscle loss while you are on these drugs. And as present, the main concern which the doctors have is that somebody with low muscle mass, we don't want to give the drug because they'll lose muscle more. So they are trying to develop drugs which will preserve the muscle mass while allowing the fat to go down. And with the coming of those drugs, we'll be able to use these drugs in a greater number of patients. So, obesity will be the main driver of a lot of health problems in the near future. And because these drugs have the capability to tackle obesity, I think we have some good hope in the horizon that will have better outcomes in obese people as the time goes forward.
That's great news. So, finally, if our viewers or listeners have to take one message home from today's conversation, what would that be?
So, what I'll say is that if you are obese or you have health problem related to obesity, you are a candidate for GLP-1 drugs. But then you should go to your doctor and ask them whether you are a good candidate or not, because there could be some contraindications in which you cannot be given those drugs. And secondly, do not think of these drugs as a short term fix. They are not a replacement for diet and exercise. You have to diet, you have to exercise, you have to change your lifestyle, and you have to parallelly use these drugs to help you lose weight. As one of the global experts on GLP-1 drugs have said, GLP-1 drugs are not meant for weight loss. They're meant for teaching you how to lead a healthy lifestyle. And because these drugs kill your cravings, they let you come back to a kind of lifestyle which will prevent obesity in the first place.
So, thank you, Dr. Nishant, for sharing your expertise and helping us understand differentiate the myths and the controversies surrounding GLP-1 medications. And for those watching us, I hope this conversation has really brought about understanding about obesity and diabetes management. And until next time, stay informed, stay healthy, and take care.